DTHF Research Meetings, your deep dive into the latest in research.
I will just give a brief intro into your background for those who don't know yet. Dr. Namathemba Chandiwana, she's the Chief Scientific Officer and Head of the Non-Communicable Diseases Portfolio at the Desmond Tutu Health Foundation in Cape Town. And she is a clinician scientist with expertise in HIV and NCDs, and her work focuses on the intersections of obesity, cardiometabolic disease, and sleep health, particularly among women living with and without HIV. So I will hand over to Dr. Chandiwana, who will be presenting to us today.
Thanks for the kind introduction. Please let me know when you can see my slides.
Not yet.
Not yet, okay. Okay, whilst I'm working on that, today's World Obesity Day, which is commemorated on the 4th of March every year. Something that's fairly new for us in South Africa. So apart from the hat that I wear at Desmond Tutu, I also represent the African continent on the World Obesity Global Advisory Group and also head the Health Systems Technical Working Group. So I'm coming in talking about obesity, both as an HIV physician and scientist, but also looking at it from a larger lens. Okay, let me try this again.
We can see your slides now.
Oh, you can see. I can't see it on my slide. Okay, there we go.
So we can see them full screen.
Okay, perfect. So now that I've done that, let's get to it. Okay, my disclosures. So I was speaking about World Obesity Day. So every year there's a theme, and this year the theme is changing systems and healthier lives. We have put a lot of blame on the individual. Just like HIV, there's a lot of weight stigma. You know, when we blame individuals for being in bigger bodies, for being unhealthy, but there's a whole obesogenic environment that's driving that. And the systems in South Africa, and I'll speak about this more in this talk, is looking at the built environment, looking at systems that have changed, and also looking at the political environment. So when you look at changing systems, it's just not health systems, it's looking at systems across the board.
Sorry, Namathemba, just to say, I can first time something's changed. Thanks.
Sorry, Steve?
Sorry, it was, I thought that you had been moving on with your slides, but I just had the title slide. So now we see a difference. Go.
Now it's moving now. So as part of the World Obesity Federation releases an atlas every year. So that's come out today. There's going to be an email that's sent out to people within the organization, but it's available on their website. That's looking at how each country is doing. It gives you a global perspective and looking at certain regions. So what's interesting about this year, and it's a trend that we've observed, is that low and middle income countries, but particularly middle income countries, have got the highest rates of obesity globally. And we've always thought about this as the McDonald's fast food American issue. But we are having the highest rates of obesity in Africa and developing island states. So that could be in the Caribbean and places in the Pacific, and also within countries within the Middle East. However, I think our focus certainly in Africa is looking at communicable diseases. So this is just giving you an overview of our scorecard in South Africa, and we're not doing so well. We've got just over 50% of adults living with overweight and obesity. And in the obesity category is about 30%. This is using body mass index, which is imperfect. It's not a good measure of obesity. There are other measures that are more accurate. such as body roundness index, which is coming into vogue. There was a Lancet Commission that discussed this a few weeks ago. But for our setting, things like, for example, abdominal circumference, that's a lot more accurate. And what's interesting about how South Africa is doing is that there's a big skew. So in the epidemiological transition that we're in, we're having more women than men living with obesity. So the card is a bit small, but in 10 years ago, in 2015, we had about 13 million women living with obesity and overweight, compared to 6 million men. By 2030, which is 5 years from now, that will be an estimated 8 million men, but for women, it's about just under double, which is 18 million. So as we're looking at the interventions, they're disproportionately affecting women, and we're seeing this not only on the African continent, but also parts of Asia and South America. And this is also reflected in young girls and women as well. There are a couple of reasons for that, which I'll talk about a little bit later. But we've got a lot of obesity-related non-communicable diseases, about 200 of them related to obesity. So if you are familiar with the game Jenga, obesity is at the bottom. Then you can put type 2 diabetes, MASLD, heart disease, mental health illness, and so forth, and certain cancers. Alzheimer's is related to excess weight. And in South Africa currently, type 2 diabetes is the leading cause of death among South African women. In comparison, HIV is number 4. And this is really causing premature deaths. South Africa, we're a young country in a young continent, with the median age of the average African is about 19 years. And we are finding these diseases in people who are young. So this is 30s, 40s. Think of your patient populations and the communities that we serve. So we are going to have a lot of premature deaths because of obesity and its complications. And this is really related to the economic burden. So this is now accounting for 15% of South Africa's total healthcare expenditure. And this is excluding newer treatments such as GLP medications, which is a type of drug that is used for the treatment of obesity. We don't have obesity care in South Africa, but the economic burden is big and we do not have a plan on how to address it. So switching gears to children and adolescents, this is the top 20 countries with the fastest rates of obesity, growing rates of obesity in the world. And what would be, at a cursory look, none of these countries are in Western Europe or North America. So a lot of these are low and middle income countries, and South Africa is number 2. We also have a lot of policy and system gaps. So this is a wheel that looks at the most effective ways that we can look at obesity. And we've got sugar tax, which is supposed to be increased from 8 to 20%. Because of the budget delay, we haven't heard. We're hoping to hear that by next week. We've got limited guidelines on obesity and physical activity, though this is, we're hoping that these will be the first guidelines, will be released in South Africa towards the end of March, early April. Physical inactivity. Less than half of South African adults get the recommended 150 minutes of exercise per week. And if you compare this to women and men, women are even less. And there are also socioeconomic disparities. So if you think about the neighborhood you live in, do you feel safe to walk around? Do you feel that there are enough green spaces? And would you say that that is true of the average South African? And that's not. And cost-effective anti-obesity medications are not available, both in private and public. I mean, we've had the Kardashian effect, where everybody's looking for drugs such as semaglutide, Ozempic. And with all that, coming from an HIV lens, which has been one of the best programs when we look at a public health program, what lessons can we learn? So this is looking at life expectancy among people living with HIV and without HIV all around the world. And we have found that HIV life expectancy is about the same for people with and without HIV, which is amazing because of all the new and wonderful drugs that are easier to use, easier to take, and also have got a good side effect profile. But what you may not know is that even though life expectancy is about the same, people living with HIV live 16 fewer good years in good health, mostly because of cardiometabolic and cardiovascular diseases. So the top ones, cardiovascular disease, stroke, hypertension, and some heart disease as well, metabolic disease being a big one. If you're looking at type 2 diabetes, certain cancers, and dementia. And this is looking at countries where we have both high rates of obesity and HIV. So half of people living with overweight live in just 2 countries, which is South Africa and Mexico. So if you're looking at South Africa, which is quite red hot at the bottom, so we have colliding epidemics, which is obesity, its complications, HIV, tuberculosis, and other things as well. And weight-related disease have eclipsed TB and HIV, and the annual deaths from obesity and overweight are now 4 times as high compared to what we think are the usual causes. So obesity is a difficult disease. I like the definition of the Canadian Obesity Society. That is, obesity is a multifactorial, relapsing, complex disorder. And there are a few things that push obesity. We've got genetics. As they say, choose your parents very well. About 30% of obesity is genetic. However, we are also living in an obesogenic environment. So if you think about when you drive home from work, how many fast food restaurants are there? When you try eat something healthy, what is competing for your attention? When we have a work event, is there water or is there sugar sweetened beverage? And also there are some developmental issues. So we know that children that are small in utero are primed for obesity. And in South Africa, where we have some of the highest rates of stunting, as well as malnutrition from underweight, that is priming you for obesity in adulthood. And certain behaviors as well. I mean, food is something that is, if you think of how we all were during COVID, we're baking banana bread, we're eating a lot, the fridge was calling your name, and that is linked to stress and other things. So obesity is a multifactorial disease, and that's why it is so difficult to treat, because you're not treating a causative agent in malaria or HIV, for example. You're looking at people's genetics, which they can't do much about, their environment, which is difficult to, and development and behaviors, which are really, really difficult to break. So as we look at obesity, obesity is a chronic disease, just as we look at hypertension, HIV, type 2 diabetes, but it's one of the only diseases that patients think that they can deal with by themselves. So, I mean, this is the one thing that I really would like to leave you with, is that this is a chronic disease. So when we shift gears to people with HIV, you've got general risk factors when it comes to obesity, and we've got HIV specific. So the general risk factors, as we age, our metabolism goes down, and central obesity, family history, social inequity, and so forth and so forth. But HIV specific risk factors, we find that women are more likely to have obesity, as well as people who started at lower CD4 counts and higher viral loads. Some of the older drugs that we have used have been not metabolically non-neutral, so stavudine, zidovudine, and so forth. So if you look at people who used these drugs in the past, we can see a certain phenotype when it comes to obesity. Chronic systemic inflammation, which is not reduced when we look at the gut, when it comes to some of the drugs that we use, that we know that inflammation centrally and in the gut, that I'll talk about in a little bit more detail. And some of the current drugs that we use are not necessarily linked to cause obesity, but are linked to obesity. For example, efavirenz-based ART, in some patients that were slow metabolizers, which means it was a toxic drug, and that prevented you from gaining weight. Now that we're using dolutegravir, for example, we're seeing weight gain in the same population. So there are a lot of metabolic complications of HIV. Because we only have a short period of time, I'm really going to be talking about the top 3, but I want you to be aware when we talk about metabolic complications, there are many. So I'll be speaking about obesity, insulin resistance, and type 2 diabetes. Something that I think is quite understudied, especially in the South African context, is metabolic dysfunction associated steatotic liver disease, or MASLD, which is what we used to call NAFLD previously. So non-communicable diseases, there's a study called POPI. This is a longitudinal study of people living with HIV. And when we are describing non-communicable diseases or metabolic diseases, we also have to look at multimorbidity, because diseases don't walk in a neat box. So in this longitudinal study of patient cohort, which is roughly 10 to 15 years older than the average South African cohort of people living with HIV, we found a few patterns, which were 6 patterns, where we had a lot of cardiovascular disease, which is in the pinkish color. We have cancers, metabolic, which we're going to talk about, dyslipidemias, type 2 diabetes, STIs, and mental health. Age is an important risk factor. So as you age, you're more likely to get obesity and obesity-related conditions. But in South Africa and many other countries, where half of people living with HIV will be over the age of 50 by 2030, we really don't have good geriatric care. I don't think 50 is at all geriatric, but we look at HIV as a young person's disease. So even when we counsel people, even PrEP, HIV treatment, STI, we focus on young people. Think of the materials that we have, IEC materials, but for older people living with HIV, where we're going to see more people, this is an important factor. I and other people within the unit have been working on the HIV and aging guidelines with the Southern African Clinician Society. So this gives some guidance, a lot of it aspirational, because our healthcare system, both public and private, is not catered for the older adult. So why are people living with HIV at risk of metabolic disease? So this is one interesting hypothesis, which is called the leaky gut hypothesis. And in this hypothesis, we are looking at the gut. So when we look at inflammation, we often look at systemic inflammation, CRPs, and so forth. But in the gut, we are finding even people who are treated and are virally suppressed. There's a study that I was involved in, which was at ARI, where we did some gut biopsies and colonoscopies in people living with HIV. And what we found was very interesting. So before they were treated with a GLP, which I'll talk a little bit more about, we found that they had high rates of gut inflammation. And afterwards, we found that inflammation went down quite significantly. So we're having depletion of CD4 counts, CD4 cells in the lining of the gut, which causes a leaky gut and alters our intestinal microbiome, which puts you at higher risk of cardiometabolic disease. And we know that people living with HIV are twice the risk for cardiovascular disease and 4 times for diabetes, for example. And the pathophysiology of obesity. So I've talked about the environment, but there's something that HIV itself does to your fat cells. So if you're looking at my left, your right, and you're seeing the effects of HIV on the fat cell, there is some changes that HIV itself does because of this chronic inflammation that we are seeing, that it does something to our fat cells. And then you're finding a bigger bound of weight, which is more than a return to health. And this study is a little bit old, but what I found quite interesting about this is when people, it was called the SMART study, a really interesting study and seminal work in the field, where we found that when people discontinued, when they discontinued ART, that there was an increase in non-AIDS comorbidities, specifically cardiovascular, renal, and liver comorbidities. So this is a study, the advanced study that I was involved in, where we followed up a cohort of 1,000 people over a period of 5 years with an extension on 3 different ART regimens. So the green one is our previous standard of care, the orange one is our current standard of care, and the top one is TAF FTC, which is available in Botswana, for example. So what we found across the board, that there was a gain of weight, there was treatment emergent obesity at about roughly 10 kilos for women, and for men just over 6.5 kilos over a period of 5 years. But this is on average. We had patients that gained 15, 16 kilos, and most weight, if you're looking at the gradient, was within the first 48 weeks of treatment. And this cohort, the median age was about 32 years at ART start, plus 5 years at about 37. And we found then treatment emergent hypertension, type 2 diabetes, and other complications as well. For women who were pregnant, there were some adverse events related to weight. Now, if you were to superimpose this on us, the biggest program with about 5.5 million people living with HIV, this is a ticking time bomb for which we're not prepared. And what we're seeing in people living with HIV is at an accelerated pace, but it's mirroring what we're seeing in the general population. And in a continuation of this study, which was advanced, we called back a few patients that had about 172 patients, some of them that were on efavirenz, and they went back to the standard of care, which is TLD, and those that were on TAF LD on TLD. So those that moved from TAF lost about 1.2 kilos, which was statistically significant. This is just in a year. And those that were on efavirenz, which I spoke about, that they're slow and fast metabolizers, gained a median of 2.9 kilos. So just to sum it all up, in people living with HIV, we are seeing a lot of drivers of obesity, which are much more than return to health. So we've got certain regimens, which is integrase inhibitors, and TAF specifically, certain ethnicities, Black women having the biggest increase in weight, as well as certain urbanization and lifestyle factors, which I spoke about at the beginning. And then what we're then seeing on the other hand and describing, and we don't quite have a handle on, is all the things that are related to obesity and its complications. But what will that mean for people who are at 40, 50, 60, 70 in the South African context? So going back, I'm going to speak about type 2 diabetes, which is a growing health threat for people living with HIV and also without. And we're seeing this in numerous cohorts around the world, that we're seeing treatment emergent obesity, and type 2 diabetes. Interestingly, there was a nice study that was done in KZN that looked at people who are in care, HIV care, and the median time to type 2 diabetes diagnosis was 5 to 8 years. And these are people who are in care. And this is quite disturbing, right? Because you think you're in care. So one of the things that with HIV, we've got good ways that we check CD4 counts. I'm not CD4 counts anymore, viral loads and so forth. But when it comes to things outside of HIV and cardiometabolic complications, we don't do well enough in. But this is also an opportunity because we have that platform where we have lay counselors, nurses that are trained for us to do integration with non-communicable diseases, obesity and type 2 diabetes specifically. We could do that a little bit better. When I speak about metabolic dysfunction associated steatotic liver disease, previously known as fatty liver disease, and if you're looking at MASLD itself and MASLD in people living with HIV, in the middle, we're seeing colliding factors. So MASLD affects about 30% of adults globally. And we have a progression. So it's just not MASLD. So we start off with MASLD, which is metabolic associated, and then to steatotic liver disease, and then to MASH cirrhosis, which at that point is not reversible and puts you at highest risk for liver cancer. And it's an independent risk factors for type 2 diabetes and all-cause mortality. But when we look at metabolic syndrome, MASLD is the least recognized component. But if we think of the bloods that we collect, for example, a full blood count, from there we can calculate something called a FIB-4 score, which is quite sensitive, and we're able, and a prognostic factor for liver cirrhosis and also stiffness of the liver. So this is something that we are working on. A lot of people are, I know some people as well, at our unit looking at MASLD. So the prevalence and characteristics of MASLD, this is a really, really nice paper that looked at 43 studies that included about 8,000 patients. And they looked at those characteristics. And this was before the name change from NAFLD to MASLD, but the results are similar. The study was in 2021. So there are potential risk factors, which are the traditional risk factors that we know of, which is excess weight, but there are also HIV-specific studies. But the prevalence of MASLD and MASH and fibrosis are largely unknown in people living with HIV. And in this meta-analysis, that was looking at the burden of NAFLD, MASLD in people living in high and middle income countries. There was no evidence from the whole African continent, which is a big gap. So this is a really nice meta-analysis that's looking at data gaps from the African continent. So as people are living longer because of ART, women in particular are living longer. So lifespan is now just at about 64 years, and women are reaching older ages. And this is something we didn't expect. As I said earlier, we look at HIV being a young woman's disease, but more than half of people are going to be over the age of 50. And there's a big knowledge gap, especially when we look at menopause as a cardiometabolic transition. So we've got menopause on one side and HIV on the other side, and with HIV medication. So we know menopause, women lose the cardioprotectiveness of estrogen, and they're at greater risk of cardiovascular disease, MASLD, insulin resistance, and so forth. And then on the other hand, we're seeing that HIV increases those risks. And then you're having that confluence. But when we look at our guidelines and how we look at women living with HIV who enter menopause 8 to 10 years earlier than women without HIV. So the median age of menopause is about 52. So within your early 40s to mid 40s, we're seeing women with HIV entering menopause. This is a good resource that I use with our patients, and I think it's really, really amazing. It's a guide for menopause for people living with HIV, both for healthcare workers and also for patients themselves. So this is something that's really important. Menopause and women's health is badly taught in medical school and in continuing medical education. But this, when we have 60, almost 2/3 of people living with HIV being women, this is something that we need to look at in more detail. So coming to my concluding slides, what are the possible strategies to address metabolic disease in people living with HIV? So lifestyle interventions, I mean, we tout a lot about, we've not done prevention well. And if we look at the WHO and World Obesity Federation, the targets that we're looking at is 0% increase. So they're not ambitious at all. And no country in the world has been able to reach that. So this whole old adage of eat less, move more doesn't quite work. It's like the ABCs that we used in the early days of HIV, which is abstain, be faithful, condomize. That was not really helpful. Yes, it's part of our toolbox, but it's not helpful when we look at people's lives. If you think of the grant that we have of 350 rands a month, and if you look at the food basket, what can you buy at that cost? So it's not to shame people who are poor on how they eat. Switching ART regimens, also a complicated one. TLD, roughly right now, it's about $75 per person per year, which is the cheapest that we've had antiretroviral treatment. It's robust, it can be used across lines, and it's fairly well tolerated. We've got a few drugs on the horizon, especially we're looking at longer acting injections, antiretroviral injections. What will that be like? So switching ART regimens, on paper, there've been some studies that's looking at doravirine to see if that is better for cardiometabolic health. And it may seem that way, but TLD is a good regimen. Public health interventions, which I'll talk more about. I mean, we talk about a lot of education and awareness campaigns, improving access to healthy foods, but a lot of this is actually outside of health. So we've got a strategy in South Africa. I mean, South Africa, we're great with our strategic documents, but we fail when it comes to implementation. But these are documents to look at where we're looking at integration. And in the current funding environment, integration, looking at community-based, patient-centered interventions is important, and also looking at policy changes as well. This is a separate talk on its own, which I would like to give later on in the year, which is looking at some of the drugs that are available. But remember, within our basket, it's just not drugs. We can't treat our way out of the obesity epidemic, but we've got such amazing drugs available. Semaglutide, which is known as Wegovy, has just been registered in South Africa in the last 2 weeks, but is not available. So we will have best-in-class treatment, but the cost is unaffordable for a lot of South Africans. But we've got behavioral interventions. So as we look at our social behavioral unit, what kind of things can we put to as part of our interventions, physical activity, writing exercise prescriptions. And while we have these novel drugs, which is liraglutide, semaglutide, and tirzepatide, which is also available, which is a good drug because it's looking at both GLPs and GIPs, so it works across. And we're looking at about 20% weight loss. So these drugs we now call bariatric medicine because we are getting outcomes almost as good as bariatric treatment, a bariatric surgical treatment, and with better drugs on the horizon. But we've got other drugs that have been around for a long time, phentermine, naltrexone, bupropion, and orlistat, which is though not a great drug, but this is what we have in our basket. But will these strategies work for people living with HIV? We think so, but there are a couple of things that we want to know about people living with HIV, I'll go back to that leaky gut hypothesis, that the way that these drugs could work is more than just looking at weight as an outcome, but reducing that chronic inflammation and reducing the risk of cardiovascular and cardiometabolic disease. And if they're operating both at weight and also looking at the gut, if we're looking at prioritizing, in South Africa, we've got so many people living with obesity, we would need to prioritize on more than just obesity. So is it obesity plus type 2 diabetes? But how these drugs could work, it could put people living with HIV at the top of the queue because of the broad-based benefits. So the cost of inaction, we saw this in our terrible times of beetroot and African potato, that delaying evidence-based interventions costs lives. And we're at a crossroads in South Africa, which we saw in the early 2000s, that by us intervening late, there were about 200,000 infections that happened during that time, and about almost 400,000 deaths. So there are a couple of lessons that we can learn from HIV, that these levers that we activated, which is community-based, grassroots-based interventions, which are really, really important, working together. That is just not having a package of interventions and giving them to people, but people telling us. So organizations that we worked with in HIV, TAC, Section 27, HELA, are now with us when we look at obesity and its complications. This is something that we did last year on World Obesity Day, where we were using the same mobilization, political will, some of the drugs, being able to work with the medicines patent pool to get both originators and also generic manufacturers to ramp up production using those same lessons, and also some of the lessons around the approach. How do we scale it up? So there are quite a few lessons learned. We did an editorial this time last year describing what some of these could be. So metabolic health also includes HIV management. This is an older slide, but the principle remains that when we look at 95, 95, 95, that there's the third 90, that's looking at quality of life. So we have changed HIV from being rapidly fatal, but now we are then looking at all the cardiovascular disease, cervical cancers, metabolic health, type 2 diabetes, which are actually higher and are the real issues of people living with HIV. So as we look at our patients, let's not just look at viral endpoints, but all these other endpoints as well. So in summary, modern antiretrovirals are amazing, but there is a risk of ART emergent weight gain and metabolic disease, which we're seeing in people living with HIV, but this is mirroring what we're seeing in the general population. Our understanding and trajectory of cardiometabolic complications is lacking. So we need to have more longitudinal studies and interventional studies on our populations. Though several strategies on these risks are being trialed, we do need to also test these novel medical therapies. And we also need to find culturally appropriate and affordable, scalable interventions. So for example, people living with HIV losing 20% of their weight in a space of a year or two. What does that mean when we're looking at HIV-related stigma and that intersection with weight stigma? And with the current funding landscape, where USAID's being dismantled could affect non-communicable disease, we really need to prioritize, narrow our focus on getting the biggest bang for our buck across diseases. So there are a few things that are happening this week. We've got a fun walk at Masiphumelele. Please do come and support. This is really raising awareness around obesity. We've got a world, the WHO is doing a Q&A at 5 p.m. South African time, where you can ask a range of experts on certain things. So again, we can put this in the chat if you'd like to be a part of it. And then lastly, for people who are interested in giving a talk looking at obesity, sleep apnea, and metabolic health this evening. So this is at the end, and thank you so much for your attention. Please open your cameras if you feel comfortable, and we can go to the Q&A if there are any questions, comments, things that people would like to share.
Great, thank you, Nomathemba, for the fantastic talk. Yes, like you said, the floor is open for any questions. If you prefer, you can raise your hand, or you can just go ahead and unmute yourself. I see Steve and Satya, they're already showing their face. They can't wait to go ahead and ask their question. Innocent's got his hand raised. So who was first? Satya, I think you can go ahead if you have a question. Unmute yourself.
Thank you, Nomathemba. That was an absolutely great talk. I think you covered everything so holistically. As my question goes, I think I'm from Malaysia, and we are still using efavirenz-based ART. So we do know that with dolutegravir, the weight gain, which is again multifactorial, could be one of the problems that we are looking at in South African context. So if a patient has been on efavirenz and is well, and now we've switched to TLD in South Africa, do you think there is a role to revert back? What's your thought?
So, I mean, what you're bringing up is something that I've heard with clinicians, even in South Africa, saying, if efavirenz was not so bad, let's keep people on it. But efavirenz is a difficult drug. I had one patient say, please take one. So I took efavirenz one day, and I have not taken LSD, but I felt pretty rough, right? I can't, it's a toxic drug. And we are trying to have the best in class, just not because when we look at health, it's just not weight, right? You're looking at how people feel. You're looking also, efavirenz is not cardiometabolic neutral. We're seeing lipid dysfunction as well. And when we don't have a lot of options after dolutegravir, you want to have NNRTI resistance is a big issue that we have in our context. So we want to keep people on a drug that is robust. And so some people say, if it's not broken, don't fix it. But I think we should advocate for our patients, because what we're seeing in people living with HIV, right? Obesity is a problem in and outside of HIV. So some clinicians want people to lose weight before they're transferred. My thing is that you want to be on efavirenz yourself? And I would say emphatically no. So best in class, because we're looking at just beyond viral endpoints and also beyond weight endpoints.
Thank you.
Great, Steve. I think your camera came on second. You can go ahead, and then we'll get to Innocent next.
Nomathemba, that was fantastic talk. I was really riveted. You speak so well, and your message is so clear. A lot of work's gone into that, and wondering if you might be willing to share your slides. I want to study them a bit more.
Yeah. No, all my slides I will share. So I'll give them to Nadine. She will circulate them.
All right. So great. I did want to pitch a question to you. So you described the emergent obesity, let's say, specifically weight gain, following ART initiation, and you described how the weight gain is way in excess of what one would expect with a return to health phenomenon. And there are two possible mechanisms of that. One might be the drugs themselves, although I doubt that then these drugs do have side effects, but there are a heck of a lot less side effects than the early drugs we used to have. The alternative would be that the drugs allow survival with amount of time, survival to allow expression of what otherwise might not have been expressed. In other words, underlying pathology, whether in the gut or elsewhere. So I guess the question is, what's your feeling with regard to the proportion of blame we could assign to the drugs versus the proportion of blame we can assign to the underlying disease that has messed with the metabolism, messed with and that would be obesogenic once you take away the emaciation effect of HIV?
That's a good question, Steve, and thank you for the compliments. And without an easy answer. So we know who is more likely to gain weight, and also in that first year. However, I think both of the things that you said are true. So if you remember the pathophysiology that's looking at the fat cell, something about HIV itself does something to fat cells, and also dolutegravir has been involved in some basic science studies in those signaling of fat cells, and even certain hunger hormones, leptin and ghrelin. I'll speak a little bit about that in my evening lecture today, where I'm speaking about obstructive sleep apnea, do interfere with that. So if you were to look, one of the things that it's definitely beyond return to health, because one of the things I didn't say in advance is that the median starting viral load was about 360. So we're not finding people who are very sick, right? People who are relatively well, even the starting BMIs weren't that low. And you'll see that when I share the slides. So I do think it's a combination of factors, but we do need other studies that really give us, because when we are looking at, I'll give specifically the South African program, we need to know who do you work on, right? So someone comes to you and you start them on ART today. What kind of prognostic factors when it comes to obesity do I want to counsel someone to say, this person comes in with 1, 2, 3. This is a person who I might want to start a combined GLP or weight management as they start ART because of these prognostic factors. But those are studies that, there's so many studies that we need to do, and that is one of them.
Okay, so, Steve, if you're happy with that answer, then Innocent, you can go ahead and ask your question.
Thank you very much, Nadine. Thank you, Nomatemba, for such an elaborate presentation. I just kept on my screen till the end, for sure. I really admire you. So I have a comment on the women's health.
Yeah.
From your presentation, it came out clearly that women living with HIV get to menopause 10 years earlier than these other ordinary women. Mm-hmm. And we're already seeing that they are already predisposed to getting obesity more than men. Is estrogen replacement or hormonal therapy something you would consider for women living with HIV in their premenopausal period?
In the premenopausal period, perhaps not, but I do think there are things like, for example, we don't deal with menopause just generally as the medical fraternity and sorority. We don't deal with menopause well. So some of the things that information you'd like to give women as they go into menopause is for them to start strength training, right? That's more important than cardiovascular because that does things for your bone density, for weight, and also insulin sensitivity, to increase their protein intake. There are studies that look at creatine, for example, and what that can do as being protective. So, I mean, hormone replacement therapy is definitely important, especially managing the side effects of menopause. But there are other things as well that we should be doing to optimize women as they go into menopause. So one idea that I have is, like we have a road to health card in children, is to have a road to healthy aging. So as you are in your 40s, 50s, or 60s, you go to a clinic and someone will say mental health, tick, 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 because We often do curative care, but we do little to none when we look at preventative care, and particularly in women's health. So I think, yes, HRT is very important, but there are other things that we can do. So weight training, exercise, those are things that we can do now. You don't need sophisticated things to do squats and press-ups, for example.
Thank you. Thank you.
Okay, thank you, Nomathemba. So to hear if there are any other questions or see, I didn't see anything in the chat. Is anyone else, anyone who's raising a hand? Don't see that. Okay, Nomathemba, is there anything else you wanted to add?
I think for today, that's that. But I would like to do another series in the second half of the year around like some of the interventions. So today I looked at metabolic. There's also cardiovascular. There's so many things that are associated with HIV and cardiometabolic disease. I mean, something that I'm very passionate about is muscle D, for example. But I think the parting words that I just want to leave everyone who is working with people living with HIV and without HIV is that there are things that we can do now. I mean, I think when it came to HIV, we were organized, we were together, we had like guidelines, etc. But obesity, we kind of like, the response is flaccid at best. But there are things that we can do on a day-to-day, both with our patient populations and also with our communities, around letting people know, giving them some information. So that would be my call to action. I know it's World Obesity Day. Yes, it's a day, but it really, I think days, like whether it's TB Day, Type 2 Diabetes Day, etc., they just remind us about what's important. And especially looking at the scorecard in South Africa, it's pretty dismal. It's pretty dismal. But we have got a lot of work that we need to do. But not to depress everyone. Thank you so much for your attention. I'm really excited to share this work. And if you're available for any of the other 2 events that we're doing, but particularly on Saturday, please register, reach out to Nadine. She's got all the information. And have a good afternoon further, everyone.
Great, then thank you again so much, Nomathemba, for coming out today. We'll definitely have you back later in the year. And then just also anyone who needs some more inspiration into hearing or a reminder of how what needs to be done to change systems, there is a video of Nomathemba when she recently spoke to the World Obesity Federation. You can find it on our social media. So on our LinkedIn, our YouTube, our Instagram. So that's I think a 90-second video for a quick inspo that you can also feel free to share with anyone you think might be interested. And then see you all on Saturday.
DTHF Research Meetings, your deep dive into the latest in research.